You are seeing my title slide, Challenges in Diagnostic Medicine, which is the topic of my talk today. And hopefully you will allow me the flexibility and creativity to explore something of a new perspective around understanding diagnostic medicine. But first, a bit about who I am. I want to acknowledge that I am a guest on this land, and I would like to give my respect to its first inhabitant. So I will share with you that I am presenting currently from the region of Peel, part of the treaty lands and territory of the Mississaugas of the Credit. For thousands of years, the Indigenous peoples have inhabited and cared for this land. In particular, I acknowledge the territory of the Anishinaabe, Huron-Wendat, Haudenosaunee, and Ojibwe Chippewa peoples, the land that is home to the Métis, and most recently, the territory of the Mississaugas of the Credit Nation, who are direct descendants of the Mississaugas of the Credit. I'm grateful to have the opportunity to live and work from home on this land. I identify as an immigrant female of Asian descent. My preferred pronouns are she and her. At McMaster University, I am an education scientist with a strong cognitive psychology lens, which I apply to develop and evaluate education innovations. And my primary research focus is clinical reasoning. And I approach concepts in education from this cognitive psychology perspective by trying to understand underlying theories that explain phenomenon related to the human mind. But today, this is where I get a little creative, and hopefully you'll bear with me. I'd actually like to challenge my own research program, which relies on a cognitive science model of categorization. Why I thought this conversation was important to have is that in the context of medical education, when it comes to diagnostic medicine, I think it is very problematic if we continue to focus on a model of diagnostic reasoning that is treated within the domain of the single clinician's mind. And that's really the dominant perspective of cognitive science. And I would argue that staying within this paradigm primarily defines diagnosis as an unknowable talent or ability that cannot be taught. So what I think this talk is really about is starting out by framing classic research related to accurate and timely diagnosis, highlighting along the way the limitations created by this classic research. And hopefully you'll agree with the way that I've framed things. And then I'll close off by identifying some future directions for improving how we teach diagnosis throughout the career of our clinicians. Okay, so first, a really quick summary of research on diagnostic medicine, diagnostic reasoning through the years. So here are four main themes in the classic research of these domains. And while if you're scanning the text on the slides, then you'll see that there's little time windows assigned to each of the four themes. And while that marks the sort of impetus of these approaches, it certainly doesn't mean that they started and ended at that time. These four themes continue to be prevalent even today. And so around the 1970s was the first time that researchers and cognitive scientists began to propose that partnering humans with computers could improve diagnostic medicine. However, the model of the human mind was ultimately flawed. And that model, in interesting kind of juxtaposition, both influenced and then became modeled after the design of those early computers that were showing up in the 70s. And it led us to believe that humans and computers were optimal when they followed a very linear sequential style of processing. We realized through research that that was not true at all in terms of how we function best. Computer systems of today are better suited to meet our needs. Artificial intelligence, machine learning, all of that is built more closely to how the human mind actually performs in terms of parallel automatic processing that's based on most likely outcomes. And unfortunately, this dominance of the cognitive science model has prevented us perhaps truly embracing some of those advances that we've made around computer systems and integrating computers into our workplace. So just I'll quickly keep going through just to highlight the other three themes of research that focused on how computers are better. So again, in the 80s and 90s, the researchers, clinicians, educators, really everyone was focused on trying to make the human mind more like the computer, teach clinicians rules, probabilities, and risks. But we learned at the end of that humans did not like to apply computer logic. Saying it out loud like that, hopefully it's not a surprise to you. But I imagine most of you are still familiar with the idea that learning about probabilities for the prevalence of disease and incidence could be beneficial knowledge for clinicians. So it's still pervasive today. In the 1990s, people began to explore more social psychology and other kinds of cognitive psychology research paradigms, like think aloud protocols, to explain how clinicians think. The expectation was that these introspections would really tap into the processes that they were using. But the limitation of the human mind is that we can't actually examine our own thoughts and truly understand them ourselves. And so that really only went so far. And our current model appreciates that skilled, expert diagnosticians are defined by their experience. So all the patients that they've treated previously. And so it's prior experience that is prioritized in our training for medical students. And creating all of those robust prior experiences for novices has been the goal of much of clinical reasoning research or diagnostic reasoning research. Additionally, in terms of framing the current dominant paradigm for how we approach diagnostic medicine, the Institute of Medicine raised concern over the rate of diagnostic errors. And when they did so, they contrasted error with diagnosis that was accurate and timely. And so with this call to arms to kind of improve diagnosis so that it is more accurate and timely, when you fit that into a dominant paradigm that focuses on the individual's knowledge, experience, and overall cognition, it became very popular to describe the cognitive architecture, the cognitive limitations, the cognitive marvel, etc., of the human mind. And all based on data collected from experimental designs that tested an individual clinician on knowledge for a single case. However, when you consider that particularly in the emergency department, really just anywhere, patients' health can evolve at various speeds and unexpectedly. The pandemic really taught us that we can't necessarily be prepared for every kind of health concern out there. The perceived accuracy at any one time may be a false measure. So the idea that a clinician would get diagnosis absolutely correct at a specific time point and be most efficient about that really does seem to be a false assumption and an inappropriate one. In contrast, the complexity of diagnostic medicine, the measure of diagnostic accuracy taken from a single time point really, sorry, yeah, I already said that, seems highly inappropriate, and our current measures of diagnostic performance are not ideal. So just to sort of summarize that, cognitive science has provided theory, methods, and findings for understanding clinical knowledge, problem solving, decision making, and other cognitive phenomena in healthcare in a way that takes the individual as the relevant unit of cognitive analysis. Our healthcare systems have largely inherited this approach in the way that we teach, in the way that we research, and in the way that we've designed our workplace and how we integrate technologies. And while it is understood that the mind works through a series of associations and connections, as depicted by this image of kind of connected dots, these processes are not accessible to examination. We cannot introspect in enough detail to describe how our own thoughts connect. We can't describe how we're integrating new knowledge from classrooms or labs or clinical tests, because we are not aware of all those connections. And the inability to examine those creates challenges and limitations from proving clinical reasoning at the individual level. Instead, If we focus on diagnostic reasoning as a more complex system distributed across multiple individuals and units, which is what I'm trying to depict here through this diagram taken from a study by Teresa Chan and her colleagues. We appreciate the complexity of that system and the role of the individual, but then also the role of the hospital, the way it's designed, the healthcare system, the way the patient moves through the system, the way that the clinician and the patient interact with other healthcare practitioners. We can explore the impact of decisions for ordering tests, decisions to manage patients in a certain way, limitations on hospital resources, and explore our varying capacity for error identification and correction, both as individuals, as teams, and as a larger system. Indeed, a gap still exists between classical cognitive theory that attempts to capture general principles of human performance through models of a general purpose human cognitive architecture and on the ground context specific and applied questions about human performance that reflect real world dynamics, complexities, and circumstances. And so here I propose a slightly different model, and one that to me is novel. Certainly it's not novel at all, but diagnostic expertise as an activity system that and so hopefully I've convinced you to break away from the dominant cognitive science model based on the individual. And by focusing on activity systems, we can, as with a distributed cognition model, support the measurement of human performance in these complex work activities, such that we can accommodate a unit of analysis called the activity system, allowing the study of interactions involving diverse media in the work settings, such as feedback and audit data, clinical practice data, highlighting the organizing features of these interactions that may derive from social phenomenon, material properties, and cultural shaping, as well as the internal constraints of individual agents. And I'm arguing towards moving towards the study of real-time interactions that take place in real-world situations. None of that, like I said, is really groundbreaking, but it's unfortunate, I think, that our own limitations of the cognitive science model have potentially held us back from embracing some of these adaptations. So if we break free from that mold, what I'm proposing is that we continue to maximize the potential of education strategies for novices, but really appreciate that that's where they live. So if you're familiar with education science at all, there's explorations around using distributed learning, mixed practice, case-based learning. All of those strategies are really ideal for our more junior trainees. And then it's time that we really start to invest in exploring strategies that can help our more senior trainees and practicing clinicians throughout their careers, such as team-based training and the use of both individual and system-wide data to guide lifelong learning and to initiate behavioral change. So just a really quick note on those three strategies that I mentioned. For novices, we need to highlight diverse patient characteristics and presentations of symptoms so that they can understand what they're seeing and understand how symptoms present within different kinds of patients. And we really need to leverage this influence of prior similar events by providing our junior trainees with simulated patient experiences. Strategies for the experienced clinicians include adapting crisis resource management activities and teaming behaviors, as well as creating the system to collect and provide audit and feedback. So just a few examples for how these two strategies have worked. I've grabbed some data from one particular study that evaluated the effect of teamwork and training. And while there are a lot of numbers on this slide right now, I just want to highlight one row here, which evaluated team dimension behavioral ratings in the experimental group and the control group. And what you'll see is a drastic improvement in teaming behavior from time point 1 for training and time point 2, but the control group really this was over almost a year, didn't quite improve much. And so even just working together wasn't enough to improve their behaviors. And then a second piece of data I wanted to highlight here is around the observed errors. And to me, this is the biggest impact on diagnostic errors I've ever seen. So in the experimental group, by focusing on crisis resource management strategies, you see a huge drop in the amount of errors in the experimental group from almost 31% to 4%, at a pretty stable rate for the control group. And then if you are able to tune in later this afternoon, then I'll be presenting with Sean Mondu about the benefits of providing clinical practice data, audit and feedback to facilitate customized coaching, to help you track long-term trends within the healthcare system and really focus in on quality improvement. And here's just one example, of a report card that potentially clinicians could receive to track their work hours and compare them to their peers. This is just showing sort of basic information about work time, but you could imagine including effectiveness ratings and guideline adherence and other clinical practice data. And that is it. Thank you very much.